Good morning, everybody, and welcome back to our presentations. This morning we have Dr. George Tharakan. She is a clinical haematopathologist who qualified first as a haematopathologist in 2014, completing her MMed thesis in 2016 from the University of Pretoria with distinction. Identifying a poorly resourced need within South Africa, she thereafter super specialized as a clinical haematologist from Tygerburg Hospital in Cape Town in 2019. She has worked with Albert Cellular Therapy for the last 5 years while doing locum work for Pathcare. She has worked at various sites, which included Pretoria East Hospital, Benoni, Glynwood and Witbank Cosmos, and EPH, as well as Middleburg Midmed. She has worked with both a clinical role as well as a pathologist role during this period. Currently, she has joined Pathcare full-time, where she hopes to bridge the gap between laboratory and clinical medicine, providing diagnosis and critical advice to assist the patient in accessing appropriate hematological interventions in a timeous manner. Thank you so much.
Good morning, everybody. Today I'm going to speak about myelodysplastic syndrome, which we will call MDS henceforth. So myelodysplastic syndrome is an interesting disease because patients who get diagnosed with MDS often ask me, do I have cancer? Or is this going to become cancer? Because they don't understand the concept. And I'd like to just break it down so that it's easier to explain to patients as a clinician. So you'll see on the left, I've got a nice little picture. It was something I saw actually last week. It's not really focusing well, but it's supposed to be a neutrophil, which is a granulocyte. It's characterized by pink cytoplasm and purple granulation. Typically, the nucleus is supposed to have 3 to 5 lobes. Here you'll see it's got a very distinct, abnormal, but lovely to see heart shape. That's just an example of it's not normal. Okay, so that's just to give you an idea of what dysplasia is kind of encompasses. So the basic contents of the presentation will go from definition straight through to management, conclusion, etc. So what is MDS? MDS is a clonal process. It involves the hematopoietic stem cell. It's heterogeneous in presentation, and it results in dysplasia with peripheral blood cytopenias. The important thing is that they can transform to leukemia, and we need close monitoring of several parameters to make the decision as to when to consider leukemia and when to initiate treatment. It's generally a disease of older adults and may or may not be related to toxic exposures, chemotherapy, or it can occur just with age. Diagnosis is based on clinical and laboratory features, but now genetics and flow cytometry assist with risk stratification and treatment decision-making. So there are several postulated pathogenesis. The one I'm going to focus on is MDS in aging. This is a newer concept. And it's related to the fact that with age, there is systemic inflammation and clonal hematopoiesis of indeterminate potential, CHIP. We have had a previous discussion about this, a very nice review by Nicole. And I'm not going to focus too much on the pathogenesis and the variants thereafter. Okay, so there's a new article released in February 2025, which is talking about inflammaging and its role in MDS. This is a very interesting new term that I discovered during my reading. And we'll talk about CHIP, the VEXAS syndrome, aging with hematopoietic stem cells and bone marrow microenvironment, the clonal hematopoiesis that leads to inflammation and immune evasion. So what is inflammaging? It's basically the chronic low-level inflammation that's seen with age and may lead to clonal hematopoiesis. The CHIP is age-associated. It's associated with somatic mutations in the hematopoietic stem cells that can lead to MDS or hematological malignancies. Some of the common mutations are DNMT3A, TET2, AXXL1 associated mutation. VEXA syndrome is basically systemic inflammation with a predisposition to develop MDS. It's characterized by peripheral cytopenias, hypercellular bone marrow, lower risk MDS with normal carrier types, and UBA1 mutation. So with aging, there is decreased cellularity due to decreased mesenchymal stromal cells and increased adipocytes. There is an impaired hematopoietic stem cell repopulating capacity with decreased lymphogenesis. There is increased mitochondrial oxidative stress and upregulation of pro-inflammatory pathways. There are increased myeloid-derived suppressor cells in low-risk MDS. Clonal hematopoiesis is characterized by expansion of hemopoietic clones that evade immune surveillance. There is selective apoptosis of the normal hemopoietic stem cells with increased inflammation and a predisposition to MDS. MDS also activates an alternate cell death pathway where there's release of damage-associated molecular patterns called DAPs that recruit immune cells and exacerbate inflammation. There is pyroptosis initiated by DAMP binding to TLR4 and increased reactive oxygen species. NLRP3 inflammasome activation leads to the release of pro-inflammatory cytokines. There are increased components of necroptosis observed in low-risk MDS cases. So both of these, pyroptosis and necroptosis, contribute to the MDS phenotypes across various mutations. So the important thing, and this is where the diagnostic component comes into play, there are key morphological features. Dysplasia affects all three cell lines, the white cells, the red cells, and the platelet precursor megakaryocytes. The dysplasia affects the nucleus as well as the cytoplasm. So we characterize dyserythropoiesis as nuclear morphology that involves budding, internuclear bridging, multicellularity, megaloblastic changes, with cytoplasm, with ring sideroblast, vacuolization, and PAS positivity. The importance of me mentioning this is when we do a bone marrow, we do refer to these terms and they have an important message to convey. When we mention this is a frank dysplasia. So it's something to take attention to. It often doesn't make sense if you're not familiar with that environment, but it is very important to note. In the granular sites, we have hypersegmentation or hyposegmentation. We have hypogranularity, sometimes hour rods, and pseudo-Shidiak Higashi granules. This megakaryopoiesis is characterized by hypolobated megakaryocytes with multinucleation, also as one component, or micromegakaryocytes. That just refers to the size. It's very important for me not to talk about these terms without showing you. I have to show you basically what they look like. So you can see in this picture, this is erythroid dysplasia, characteristic megaloblast. We have a very nice, lacy, dispersed chromatin of the nucleus. There is a nucleocytoplasmic reversal of ratios. And we have a erythrocyte, which has got a nucleus, and it's called budding. That is the term budding. I'm sure if you remember from biology, there's the yeast cells also cause this budding kind of a pattern in certain yeast cells. So this is a picture of erythroid dysplasia. If you see, there is our big megaloblast, but there is also characteristic vacuolization in the cytoplasm. In the granular sites, I've told you before that the neutrophil is supposed to have 3 to 5 lobes. Here there are 2 lobes. This is a pseudo-Palga-Huey form. And if you look at the cytoplasm, where it was supposed to be pink and granular, it's almost clear. So that is hypogranularity. This is your hypolobated megakaryocyte, where it's supposed to have multiple nuclear lobes, but it's just a single nucleus. Then in ring sideroblasts, we use a Prussian blue stain, and we've got a characteristic ring-like configuration around the erythroid cell, the nucleus of the perinuclear ring formation, and that is abnormal. And it's seen in the SF3B1 mutation of MDS. In our bone marrow trephine, we see abnormal precursor cells. So this ALIP is abnormal localization of immature precursors. They're usually paratrabecular, 1 to 2 cell layers, but they can be more and abnormally situated within the trephine. We've stained them with CD34, which is a marker of immaturity, and it identifies blasts. So you can see that here. Then in the biallelic TP53, this is just a picture of a patient with biallelic TP53. You can see the abnormal megakaryocytes and granulocytes, as well as the binucleate form here. So these were all taken from pathology outlines. It's very comprehensive. Now, MDS has underwent a bit of a classification change. The latest classification is the WHO 5th edition, where we characterize MDS with defining genetic abnormalities. They vary with the number of blasts in the bone marrow and in the peripheral blood, as well as the cytogenetic abnormalities seen and mutations. An example is the MDS with low blasts and a 5q deletion. Here, we typically see less than 5% blasts in the bone marrow and less than 2% peripheral blood blasts. Cytogenetics, there is only a 5q deletion or any other abnormality other than a monosomy 7 or 7q deletion. The mutations can be any except for multi-hit TP53. So I'm not going to go through the whole classification, but you can basically see that's where the variation occurs. The entities to be concerned with as well is MDS with increased blasts 2, which just tells you that the blast number is more. There's more than 10%, but less than 20% in the bone marrow, more than 5% and less than 20% in the peripheral blood, and there can be AWAROS. They are associated with multiple cytogenetics and mutations, except for the multi-hit variant. So we use for prognostication the revised IPSS score. And this is from 2012 or 2013. This was the new one that was adopted. It takes into account the number of blasts present, the cytogenetics, the type of cytogenetics, whether they're very good or very poor, the hemoglobin level at time of diagnosis, the neutrophil count and the platelet count at time of diagnosis, and each are assigned a certain score. If you just want an example, we have a very low risk group having a score of less than 1.5. Overall survival is 8.8 years, whereas a very high risk group would have more than 6 score, and the overall survival is only 0.8 years. So that's where the significance comes. And then the cytogenetic abnormalities, the very good ones are deletion 11q and a Y, deletion Y. Or very bad would be more than 3 abnormalities and is referred to as complex. So I would also like to present a patient of mine from Witbank. He's a male, he's 72 years old. He complained of blood spots in the legs and the arms of 2 weeks duration with easy bruising for the past few months and tiredness, which affected his daily activities and functionality. Systemic inquiry was negative, no comorbidities, no smoking, no drinking, no family history of significance. He presented with a hemoglobin of 8.5. It was macrocytic of 120. His white cell count was only 2 with a neutrophil count of 1, and his platelet count was 20. The rest of his chemistry and hematinic screen was negative. There was no viral exposure. Ultrasounds were normal. The bone marrow was hypercellular for age with dysplastic erythrocytes of more than 10%. They were mostly bilobed and megaloblastic forms. There were also hypersegmented neutrophils, that means more than 5 lobes, blasts of 2% and no ring sideroblasts. He had a FISH showing trisomy 8. So in summary, he had a normal BMI, not in distress, petechiae, both bilateral lower limbs and forearms with bruising on the arm post-trauma. Vitals were normal, no other systemic inquiry was fine. So the way we classify him according to the RIPSS is that he's an intermediate risk. He's got a trisomy 8, which gives him 2 points. Medullary blasts were only 2%, that's 0 points. Hemoglobin was between 8 and 10, which gives him 1 point. That's 3 in total. Platelets less than 50, 4 points. Neutrophil count was greater than 0.8, so that's 0 points. So he's an intermediate risk patient. That is 4.5 points. He has a 3-year median overall survival. His time to AML transformation is anticipated to be 3.2 years. So we can treat him because he is an intermediate risk with either low intensity or high intensity treatment. And this would depend on his age, performance status, and patient preference. So he was initially transfused with blood and platelets on a weekly basis before he got to us. We motivated for growth factors. It was a big fight with the medical aid. But we eventually got 3 growth factors support. So that is with Neupogen, Recombin, and Nplate, and he was doing very well. He had normalized his counts with weekly injections. We also then struggled after about 2 months of treatment with the medical aid because they were refusing to treat him with growth factor support. We motivated for hypomethylating agent because in this case we can. He fulfills the criteria for hypomethylating agent and growth factors. So we did motivate and we gave it to him. He was monitored weekly just so that we know when to give the growth factors. And he did well. He completed his first cycle, but he then developed a neutropenia and sepsis. He had tooth abscesses and needed teeth extractions. He did pretty well. He just got some transfusions and growth factor support with antibiotic cover while in hospital, and he started cycle 2 of his hypomethylating agent. So this is the MDS diagnostic algorithm. This also has incorporated a new investigational predictive tool that they're trying to bring to the fore. Traditionally, the bone marrow is considered the gold standard of diagnosis. So we've got a clinical suspicion with symptoms, anemia and cytopenias. Of course, we have to exclude other contributory causes. That is B12 deficiencies, folic acid, hemolysis, liver disease, medications, alcohol use, viral infections, etc. A bone marrow is needed. We do a aspirate with a biopsy. We've excluded other bone marrow diseases and inherited bone marrow failures. We look at the cellularity and the degree of dysplasia, the blast counts, and we review the flow cytometry, the cytogenetics. These are, as you can see, pertinent in us making a decision. We risk stratify the patient and we classify the MDS. Now, the investigational tools that they're trying to bring up is basically a computational algorithm that is automated without requirement of a bone marrow using peripheral blood, morphology and genetics performed in the peripheral blood, then can predict based on age, sex, and all the different criteria whether they will develop MDS. So that's the new thinking, the new investigations going forward. That is nowhere near where we are in South Africa, and we must still do a traditional bone marrow examination to make the diagnosis and manage the patient. So this tool is based on the understanding that MDS is a clonal disease, and as mentioned before, there may be a pre-MDS stage, the ICAS, CCAS, etc., similar to the MGUS that can become a myeloma, and MBL that can progress to a CLL. So this is non-invasive methods that they're trying to use and predict the probability of an MDS patient without bone marrow assessment. So we've talked about that. Now, management. How do we manage our patients? It's actually a holistic approach. As you know, it's traditionally a disease of elderly patients. Management is according to the clinical and biological characteristics of the disease, the patient, and the physician preference. It's dependent on the revised IPSS score. Low risk MDS, it's basically classifying the patients into low risk or high risk. So low risk MDS includes patients with an RIPSS score of less than 3.5 points. And high risk basically are patients with more than 3.5 points. So this is a bit small. I'm not sure if everybody can see it. So essentially, a lower risk MDS patient will benefit from supported management. Traditionally, we use erythrocyte stimulating agents. And depending on how they respond to this, we may or may not consider a hypomethylating agent, or if they have a MDS deletion 5q, these patients are given a trial of lenalidomide and they do pretty well on it. This is if they do not have any additional high-risk genetic features. Then high-risk patients, depending on the number of blasts present and their condition and the availability of a donor, we consider for hematopoietic stem cell transplants in addition to or after failure of a hypomethylating agent or after debulking with hypomethylating agents or traditional chemotherapy. So we also have this Nordic ESA response predictive tool. This is where we give a point depending on the patient's transfusion requirements and EPO levels. So if they're needing less than 2 units of red cells per month, they get 0 points. If their EPO level is less than 500, they also get 0 points. And this predicts that they will respond at least 74% to ESA stimulating, so ESA agents. If they have a higher point system, which is either 1, 2, the chances of them responding are less. In South Africa, we have ESAs, we have lenalidomide for the 5q minus, we have hypomethylating agents, azacitidine and decitabine, and we have chemotherapy and LDAC, and hematopoietic stem cell transplants. We do not have luspatercept. And these patients, so then that's basically what we have in South Africa right now. So that's the way we would go with this patient. So an IPSS, very low or intermediate risk, with symptomatic anemia or asymptomatic anemia and a hemoglobin of less than 10, and who fulfill the criteria for a higher intermediate predictive Nordic score for response should be considered for a trial of therapy with ESAs. ESA treatment should be started as soon as appropriate after diagnosis, before established transfusion dependence for the maximum benefit. We give them a trial of a maximum of 24 weeks of therapy with 8 weeks traditional ESA dose, further 8 weeks at a higher dose, and finally with addition with a GCSF stimulating agent for further 8 weeks. Then if they have failed this, they have established failure with ESA therapy, and we need to consider something else. Iron chelation therapy mustn't be forgotten because after 20 units of red cells, they need iron chelation or a ferritin of greater than 1,000. So MDS with isolated 5q. So there's usually a female preponderance. It's an indolent course. There's a macrocytic anemia, normal and high platelet counts. So the bone marrow has non-lobulated megakaryocytes and less than 5% marrow blasts. So independent predictors of overall survival include transfusion-dependent age and thrombocytopenia. So we treat them with symptomatic anemia. We treat them with the trial of ESAs. If they're transfusion dependent despite this and they failed ESAs, we give them lenalidomide at a dose of 10 milligrams per day for 21 days every 28 days. If they fail this or they have multiple cytogenetics and blasts greater than 5%, we consider them for alternate therapies, and thereafter, if they fail that, allogeneic transplant. Hypoplastic MDS have features consistent with myeloid neoplasms. We treat with MDS-related treatment or an allogenic stem cell transplant. We do need to exclude other causes like a PNH. So high risk, as I've mentioned, they can be transplant eligible or non-transplant eligible patients. So if they're transplant eligible, we try to give them an early allogenic transplant. They're usually patients who've had more than 10% blasts, and they've got other things that we need to consider, like the genetics. We'd give them an induction chemotherapy or a hypomethylating agent before we transplant them. And non-transplant eligible patients, we'd give them supportive care. We'd offer them supportive care, which is basically treating the anemia, the thrombocytopenia, and things like that, admitting them for antibiotics if they've got infections. Then we'd consider azacitidine, which is a hypomethylating agent, or decitabine. If that fails, we'd have to consider intensive chemotherapy, but obviously, if the patient is able to tolerate that. So these patients who are high risk we should initiate the discussion with the transplant team as early as possible. And then, as I've mentioned, the way to go forward with them. So here we've got patients, as I've mentioned before, it's just changing the way it looks. It's hypomethylating agents, low-dose chemotherapy, and growth factor support for the non-transplant eligible patients. When do we transplant? Patient-related factors are important. It's dependent on the frailty and comorbidity scores, as well as the patient's wishes and social support. Biological factors come into play, like low risk, high risk, genetics, germline mutations, response to previous interventions, availability of the drug, and the medical aid plan. This is very important because we can have the access to the drug in South Africa, but it's not necessarily that the medical aid will pay for it. Okay, so this is unfortunately came out poorly. It's the things that we use to determine fitness for transplant. We use our ECOG performance status scale. A patient with 0 is fully active, able to carry on all pre-disease performance without restriction. Patient of 4 is completely disabled. So it's like a score of 0 to 5, dead. But that's just part of that score. Then we've got the Karnofsky performance status score that we use, with 100 being the best and 0 being the worst. We've got our EBMT risk score. This is basically the risk factors for an allogenic transplant that we use, where we give them different scores. The higher the score, the poorer they do, and the requirement for reduced intensity conditioning. And this is just basically classifying or weighting the score of the comorbidities that the patient has. So in conclusion, MDS is a malignant clone, and its development is dependent on genetic mutations. 90% of MDS patients have more than 2 mutations. There are several genes that are associated and notorious with this: SF3B1, TET2, etc., TP53. Not all mutations are equal. Driver mutations have clinical significance, whilst others are passenger mutations, and the variant allele frequency and hotspot mutations are important. SF3B1 defines MDS with ring sideroblasts. The NPM1 and FLT3 differentiate AML from MDS. So the future of genetics is still, it's rife. There's a lot going on, but for us, practically, we just need to be aware that mutations have been found in healthy age populations. And as I've mentioned, the age-related clonal hematopoiesis of indeterminate potential exists, the ARC and the CHIP, with those mutations associated with it. Germline mutations exist that can present in adulthood. The exact implication of this is still in its infancy, and till date, targeted therapies are being investigated, but not readily available, and only a few in the South African setup. And just to understand that there is a pre-MDS states that are now recognized, the associated cytopenias of undetermined significance and dysplasias without cytopenias. And further studies obviously need to be done to conclude on the importance of all of this. Thank you.
Wow. Thank you so much. Yeah, MDS is one of the, I think what during our clinical practice we'll discover a lot of MDS cases, and the issue that of course you really don't know, and most of them is really elderly people, or they have an underlying kind of secondary cause, either retroviral disease or, and always we tend to exclude that parvovirus and all those. The question is that, what's the lifespan after transplant? Do you restore your your bone marrow function sometimes?
They do. They do, but obviously allogenic transplant comes with its own risk. A match-related donor is not always available at that age group. Match-unrelated donors need to be sourced. That can be national or international. And that's also another challenge that we face with the medical aids, whether they will approve the search for local or international donors. Then comes the risks and the post-transplant risks. So the risks are very high. And that's why you need to make sure that the patient that you're offering transplant has the understanding of the implications of that, as well as the social support that is required. We've seen a lot of very bad cases, but we've also seen some good cases. It's difficult to say. There are patients that do survive the transplant. It's not that you never do. You do. I don't have exact statistics.
But then looking at our own, I mean, I know that we do a lot of transplant in Pretoria East. I don't know whether it's centers in Cape Town. The question is that how is our lifespan of survival post-transplant? I know that most centers in Europe, they actually got to very good centers. Are we in par with them? Or
I don't think they're necessarily in par, and that's also because of the complications and sepsis that develops, the complicated infections that develop. We don't have access to all the drugs that they do in Europe. And also the patients stay far away from us, and sometimes they complicate or they don't follow. You know, there's a lot of varying factors that influence that kind of information, you know, so it is a bit difficult to answer.
And then secondary MDS, removing the inciting agent, will that make difference?
No, once
Not
it's
really.
there, it's there.
Once the damage done,
Yeah.
it doesn't. So, okay, I think that's very important because always this emphasis, like in lungs, hypersensitive pneumonitis, once we remove the inciting agent, you expect that the disease can be arrested and kind of also progress, you know, they tend to improve, you know, and yeah. So it's actually something, but so we need to look for it. And I mean, for the general practitioner out there, GPs, what are the signs that they look for? Is it recurrent anemia only?
So our cytopenias, typically macrocytic.
Biocytopenia or pancytopenia? Which are the commonest?
It's traditionally classified as a pancytopenia with a macrocytic, indices. But patients present with biocytopenia. They present with monocytopenia, like just the thrombocytes that are low. You know, I have a particular patient, she's normal everywhere else, but just the thrombocytes are just low, less than 100, reducing until we did investigations and we found that she's got a 5Q minus, but she's also got some other genetics additionally. So she didn't respond to growth factor support, and I've got her on hypomethylating agent.
Yeah, so I think probably the key point here is that you got pancytopenia with macrocytosis and round cells, not oval, round cells, okay? And that means probably then you need to really consider that as MDS, probably that's most likely, and then most of the patient need to be referred to a specialist. In this case, would be a physician. But if you have a center with hematologists, will be also very highly appropriate. And I think BMed need to be done, and diagnosed really based on bone marrow. You need to have BMed.
I think the key thing they need to understand is we've got several cases where we've got just monocytopenias or bicytopenias that we've done bone marrows on and found dysplasias. There is an entity where you can get dysplastic appearing cells without clonality / clonal cells without so much dysplasia. So if there is an unexplained cytopenia, you've excluded everything else, I think a bone marrow is warranted. So
would biocytopenia, monocytopenia come before there is pancytopenia, or is it a vice versa?
No, it's that they form. Some patients just present with an isolated single line cytopenia.
I've got a patient that I'm quite worried that I will be waking up next week. It's a lady, she's in her early 60s, I think, and she's got very, very severe eczema. So she was initially on azathioprine and a fairly high dose from the dermatologist, and she presented last year with a pancytopenia. And obviously we thought, it's related to the treatment, and we stopped the agent. And it did recover. We did give her, she got new vision and whatever while in hospital. She had a neutropenia. And then she's like kind of not followed up, lost to follow up. She's appeared to the dermatologist a couple of times where they've done an FBC. But now what I'm seeing on her bloods is she's got a macrocytosis. She's got the neutropenia again. And the platelets are not very low. They're just kind of below where they should be. But then she's also got these intermittent kind of petechiae, which she didn't present with. So we're doing it. It's been quite difficult to get her to do the bone marrow, but she's agreed to have it done next week. So I'm interested to see what's happening because it's literally a year. It's probably about almost a year off azathioprine.
And she's not taking any agents.
You've topical agents now only. Quite strong topical steroids only. That's it.
And you've excluded all the hematinics and the others.
Yes. Yeah. Look, initially we did it and it looks like it's been done since, but it needs to be redone. So I'm kind of starting at scratch again.
Yeah.
I'm worried about something underlying.
And then in terms of the splenomegaly, did they all present splenomegaly? No.
No, that's not.
So that's much more for the metabolic.
That is a diagnosis of exclusion, so they mustn't have a splenomegaly.
Yeah, so so most of the time I think, but also I think one of the things obviously you have to exclude portal hypertension, it's also very important. They can present with monocytopenia or cytopenia or pancytopenia also. Severe anemia also can give you that. So I think there are a lot of basics principle actually, go to ABC or hematology and be going back on really difficult diagnosis.
And remember, we are available. So if there's anybody who has a problem, they must contact us and we'll advise them accordingly.
I think that's very important. Yeah. So we'll provide email contact at the Pathcare and Path laboratories. They're all available and they will give you the care needed for the patients. And as I say, as a general practitioner, refer the patient to the preferred center and we can find the care for the patient.
Thank you.
Okay. Anyone online? Questions? Okay, thank you.
Thank you very much.